Over the next 15 to 20 minutes, I'll be speaking on the Indian diabetes landscape, the unique challenges what we face. So let us understand the distinguished characteristics and complexities of diabetes management in India's heterogeneous population. So we all know how much prevalent diabetes is today. So India has been the diabetes epidemic capital, which presents unique clinical challenges that demand specialized therapeutic approaches. So we rank second globally, which we know, trailing behind China in absolute numbers, and we are characterized by an younger onset and people with higher insulin resistance and rapid beta cell decline when compared to the Western population. And we have a elevated cardiovascular complications with poor glycemic control, and only 30 to 40% of the entire population achieve their HbA1c control, less than 7%. So this is a huge prevalence and background what we Indian people face today. So what is the diabetes control? We have a urban against the rural divide. So the geographic disparities in the diabetes prevalence and healthcare access, they create distinct challenges across India's diverse landscape, requiring tailored intervention strategies for urban and rural populations. So what is the glycemic control in India, which has been a major gap between the urban against the rural? If you just see, only 30% of the urban patients achieve the HbA1c less than 7, whereas at the rural level, only 17%, even lower, they have their control at less than 7%. So what are the contributing factors? So sedentary lifestyle, high carbohydrate intake, delayed treatment intensification, and we are in a land of significant postprandial glucose excursion. So let us see what we can do. So what is the principles and rationale behind having a basal plus bolus plus a oral anti-hyperglycemic therapy? So we need to explore the scientific foundation and therapeutic logic behind combining insulin and the oral agent strategies. So what is this basal bolus therapy? So we all know the basal insulin, which provides 24-hour baseline coverage. So controlling only the fasting. So what about the bolus? We know that the rapid acting insulin, which have a life of 3 to 6 hours, which is given at the specific meal times, they manage the postprandial spikes. So in spite of these basal bolus, we need a support of the oral anti-hyperglycemic agents to target the basic pathophysiology of diabetes, which is the insulin resistance, thereby enhancing the endogenous secretion of insulin. Why this basal bolus is required in Indian type 2 diabetes? First, a postprandial hyperglycemia. So as I told you before, Indian dietary patterns, they are rich in carbohydrates and a large meal proportions combined with progressive beta cell dysfunction, they create a significant post-meal glucose excursion. Secondly, dual insulin action. So the basal insulin establishes stable fasting glucose throughout the day, while the bolus insulin specifically addresses the post-meal or meal-centered glucose surges. So what about the synergy of having an oral anti-hyperglycemic agent? So metformin reduces the hepatic glucose output, we all know for years, and it improves the insulin sensitivity, whereas sulfonylurea stimulate the residual pancreatic insulin secretion, having a comprehensive metabolic management. So what about the recommendations for bolus insulin use in India? We have ample evidence even from the PMC 2021 expert panel. They provide the practical framework for implementing the bolus insulin. So introduce bolus when the glycemic targets remain at met despite optimizing basal insulin therapy along with OHAs. So what about the personalized way of approach? We are living in an era of personalized medicine. So tailor-based bolus insulin choice, timing and dosing to individualized meal patterns, cultural dietary habits, and patient lifestyle factors. Lastly, special population care. So exercise heightened caution in patients with renal and hepatic impairment, elderly people, and during pregnancy. So, start with the basal. Begin when oral agents fail with HbA1c greater than 9. Add a bolus when your postprandial excursion despite optimized basal therapy. What we have the clinical evidence from the Indian studies. So this study, Glargine plus glulysin against the premixed. So there, this design was insulin 200 patients with insulin naive type 2 diabetes patient on two oral agents randomized to basal bolus compared with patients on premix insulin. So what are the key findings? The HbA1c was reduced to less than 7% and nearly 16.8% with basal bolus against 13.1% with premix. So there was no statistical significance between again with respect to the HbA1c. So secondly, the basal bolus showed significant HbA1c reduction at 12 and 24 weeks, whereas the premix did not show. But the main point what to be taken is the incidence of hypoglycemia and the weight gain comparable between the groups. So this basal bolus regimen demonstrated efficacy and safety with superior flexibility for dose individualization, whereas the premix offered administration convenience, but it lacked precision for controlling the postprandial excursion. So the preferred choice was basal bolus, whom the patients with irregular meal patterns, who had a variable carbohydrate intake or elevated postprandial glucose. So this was the clinical trial results. If we just see the trajectory of the HbA1c from 12 weeks to 24 weeks. So the basal bolus therapy, the patients on basal bolus therapy, they achieved sustained HbA1c reduction over a period of 24 weeks, demonstrating superior glycemic control compared to the patients on premixed insulin patients. So we spoke the advantages of having a basal bolus. So what's the synergy of a OHA in combination? So strategic integration of oral agents to enhance the insulin therapy effectiveness and to address the multiple pathophysiological defects. So we know we are now living in a decade of the glyphosins. So previously we know metformin, which was the gold standard, which was preferred in overweight obese patients, and we know the physiology of action of metformin, what it does. It reduces the hepatic glucose production and thereby enhancing the peripheral insulin sensitivity. And then came the sulfonylureas, which remained as the first line choice for non-obese patients, which stimulated the pancreatic insulin secretion, thereby having a perfect insulin sensitizer with the remaining functional beta cells. Then we had the alpha glucosidase inhibitor, which was mainly useful for controlling the postprandial peak, thereby delaying the carbohydrate absorption at the intestine level. Then the decade of DPP-4 inhibitors, what it showed, concurrent use with basal insulin, had a target to optimize while minimizing the insulin doses. What about the optimization? So start slow, initiate with conservative doses to assess the individual response and thereby minimizing the adverse effects. Review regularly, screen for interfering conditions like infection, drug interactions, another thing. Then slowly titrate and just avoid blind escalation. If adequate control is not there, consider adding an insulin rather than pushing the OHA to maximum dose. This is a take-home message. So never escalate the OHAs to the maximum dose. Better prefer escalating the dose of insulin. So what about the practical approach? Step-by-step clinical protocols for safe and effective insulin therapy. So when to start a basal insulin? So you all know when to start. The clinical indications like HbA1c greater than 9 or failure of 3 oral anti-hyperglycemic agents, symptomatic hyperglycemia with polyuria, polydipsia, and weight loss, and persistent HbA1c about the target. So always start conservatively at 0.2 to 0.4 units per kilogram weight, better at bedtime or in the morning, which is feasible for the patient. and use lower end of the range in elderly patients or those with renal or hepatic, and check the fasting glucose daily or at least once in 2 to 3 days. Systematically titrate the basal dose to achieve the target and keep the target at less than 40. When to add a bolus? So we know when there is a postprandial peak and when the postprandial glucose is not under control in spite of adding a basal insulin and adequate fasting. So divide the total dose of insulin into basal and bolus. So commonly a 50-50 adjusted based on the glucose pattern. Otherwise, two-thirds of the thing with the bolus and just one-third with the basal. And administered the rapid acting bolus 15 to 30 minutes before meal for optimal postprandial thing, and adjust each bolus dose independently based on the corresponding post meal thing. So when to review? So review 3-day fasting glucose trends increased by 2 units. Analyze the postprandial glucose logs for each meal and adjust the specific meal bolus by 1 to 2 units. So the preferred approach is proactive titration using the previous day's structured glucose data rather than reactive dosing based on the current single leading. So administer the rapid acting, which I told you before, adjust the post-meal things, and these are the dose distribution which has been repeated. So what about the special considerations? We live in a diversified Indian population. So we need to tailor the therapy to address the cultural, dietary, and socio-economic factors. So tailored Indian diets are predominantly carbohydrate based with rice and starchy vegetables, necessitating insulin dosing. Okay. Comprehensive counseling needed for consistency and the basic carbohydrate counting principles is critical for the therapeutic success. So we all know that the alpha glucosidase inhibitor or rapid acting insulin, they blunt the severe postprandial spikes after each high carbohydrate meals. So with this all drugs of armamentarium, so what we need to address? First thing is to minimize the hypoglycemia. So conservative initial dosing and gradual titration is necessary. Second thing is structured self-monitoring of blood glucose is needed. Thirdly, patient education on recognizing the symptomatic tremors, sweating, and confusion is needed. How to identify the symptoms of hypoglycemia. Third, always carry fast acting carbohydrates along with the patients, especially in special populations. Thirdly, adjust the doses for missed meals or increased physical activity. The incidence of hypoglycemia is around 8.2% with basal bolus, and with respect to the premix insulin is 7.9. So almost both the things the thing. So what about the comorbidities and patient factors when you consider these class of drugs? So high prevalence of cardiovascular disease, and we need to dose reduce with respect to renal impairment patients and avoid metformin when the eGFR is less than 30, and impaired insulin clearance necessitates conservative dosing, and avoid sulfonylureas in severe liver disease, and less stringent glycemic targets is appropriate, and emphasis of safety over tight control with respect to elderly population. So exploring the broader impact of optimized therapy and the emerging innovations have transformed diabetes care. So, what about the impact of optimized basal bolus with OH? It has reduced the complications, it has improved the glycemic control, thereby significantly lowering the risk of microvascular complications and the macrovascular complications. And we had an enhanced quality of life. So, they reduced the symptomatic aspect, increasing the energy levels, thereby improving the overall well being and daily functioning. So, it has indirectly or directly reduced the hospitalization rate. Lastly, personalized medicine. Flexible basal bolus regimen support individualized treatment approaches across an heterogeneous population, and to manage hypoglycemia has been remain the most important factor with respect to patient education. Secondly, addressing the cost barriers and availability issues. Thirdly, adopting the insulin timing and dosing based on the traditional Indian meal patterns and carbohydrate-rich diets. So let me just summarize saying some key takeaways. First thing is we live in a phenotype of Indian type 2 diabetes patients who required tailored basal bolus with an add-on OHA regimen, thereby addressing the unique metabolic characteristics. So we are having high insulin resistance with rapid beta cell decline. So we need to early insulin initiation and proactive structured titration based on the glucose monitoring, which has been critical in achieving and maintaining optimal glycemic control. Thirdly, synergistic communications or combining a synergistic aspect of thing. They integrate the basal bolus insulin with a complementary oral hypoglycemic agents, which will enhance overall efficacy of the management of type 2 diabetes while maintaining the safety profile of the patients. Lastly, comprehensive patient education with structured self-monitoring and regular clinical follow-up, they form the foundational pillars of successful long-term therapy of type 2 diabetes management. So I'll just finish off with some case studies and outcomes. So this 55-year-old male from urban India with a sedentary lifestyle, type 2 diabetes with HbA1c of 9.2 and BMI of 27, highly motivated. And we started with insulin Glargine with zero point 0.2 units, and the patient was followed up, and over the next month his insulin dose was increased and his basal insulin was increased to 22 units, and gradually his fasting improved and his fasting came down from 220 to 85. After a period of 4 months, he was continued. In spite of his fasting came down, the HbA1c didn't have his target. So just with 28 units of just Sustaglar or basal insulin, he had the best control and his HbA1c. Sorry. So this second patient, this patient initial HbA1c was 9.5. He was started on metformin with glimepiride and he was followed up over a period of 3 months. Still his HP fasting didn't come down. So he was added basal insulin due to persistent fasting glucose. And when we followed up the 4th month, his fasting came down to less than 100, but still his postprandial level was very high. So he was introduced a bolus targeting the postprandial glucose, and as his history showed some high carbohydrate meals, in spite of adding an ugly bolus, his postprandial thing didn't come down. And over a period of 6 months, his HbA1c came down to 6.8 with reduced hypoglycemia episodes and improved quality of life. So this patient was on basal plus bolus with OHS. So this was with respect to type 2 diabetes chain. So with these two backgrounds, the first case only with basal, he had a very good control. But the second case, in spite of basal, bolus and an OHA only, he had a tight control. So this is a varied and diversified population where we need to approach each and everything individualized. So we need to have an evidence-based practice, a multidisciplinary collaboration. We need to spend time on education. We need to transform lives. So together we can reduce the entire diabetes burden and we can live a diabetes free world at least in the future, and to prevent a diabetes free complications in future life. So thank you once again for Regenix for giving this wonderful opportunity. Thank you all for a patient hearing.